Hello, everyone. Today, I will be re-recording this presentation that I gave a couple of weeks ago in Milan in one of the international meetings in aesthetics and aging. So without further ado, let's start. So this presentation was regarding regenerative medicine and where we are right now in the world of aesthetics. So let's start first with some definitions. What is regenerative medicine? And especially when we are talking about aesthetics. And regenerative medicine in aesthetics refers to the application of these principles of regenerative medicine in the aesthetic or cosmetic treatment, products and services. So what this means? It means that we are trying to harness or regulate the body's own natural potential to repair, restore, and rejuvenate damaged structures and healthy and useful state. So we are trying to use the body's own capacity to basically go back to a youthful and healthy state. So when we talk about, like regenerative medicine in aesthetic, we are talking about, replacement, regrowth of tissue that are damaged, structures that are damaged. But is this something new? Because if we recall, antioxidants or retinoids, just to give two examples of this, have been doing this. We know that when we take efficacious antioxidants or when we apply efficacious antioxidant to our skin, we can see improvements in the healthiness of our skin. We can see improvements in the levels of our own antioxidant capacity, how our cells are able to defend themselves from oxidative stress. When it comes to retinoids, especially those efficacious forms of retinoids such as retinoic acid, retinal, and retinol, we can see replacement of damaged collagen by new collagen. And healthy looking skin and more firm skin starts appearing as we are using this product. So one of the questions that I always put to the audience when we are talking about regenerative medicine is like, are we talking about this when it comes to new technology, or we are also acknowledging that the old technologies are doing this from decades and we were just not putting them in this bucket? So something to take in consideration. Okay, so how this is regulated, and this is a big issue right now because everyone is talking about, like regenerative medicine. We are doing this. We're, like different claims. Like marketing always take the wheel and leave the science sitting on the seat behind, which is a pity. But what is this about the regulation of regenerative medicine? So because this is something that changes the function and structure of an organ, in this case the skin, it has to be FDA regulated. So this needs to be basically the FDA in the United States is the one that license and approve procedures to be marketed to consumers as part of the regenerative medicine, like approach. And for this, the FDA needs to be involved, oversight in clinical trials. And these clinical trials are usually very large, very expensive, and it takes years to happen. So if you don't see, clinical trials that include the thousands of people with placebo control or like a very well-designed clinical trial, it's very unlikely that the technology that they are trying to tell you that is, like FDA approved for, or like, is regenerative medicine has the clinical data to support that. If you go to the website, the FDA website, and you type regenerative medicine in aesthetics or regenerative medicine itself, you will see there is a long list of things that they are not approved for regenerative medicine, and a very short list of diseases that are already on the path to get some regenerative medicine treatments involved on their treatment or their potential cure. So when it comes to regulation in the EU and the European Union, this is way more complex than, like as an American, I wanna, like take on my hands. So most of the time what we do as American, we hire lawyers or agencies to deal with this. But in the European Union, basically what we have is different agencies that are overseeing different steps of the process, like clinical trials or, preclinical data, as well as different technologies. They are divided, like in different technologies to accomplish basically a faster evaluation of this potential new technologies. So which are the most common regenerative medicine therapies in aesthetics? And these are stem cells, PRP, exosome, and the new one that I added right now are the biohacking therapies. So what I will do in the next couple of minutes is like, I will go over these, therapies, but I will not show you a lot of data, but I will give you some of the questions that you should be asking whoever is trying to, argue for this, therapies, and see if we can start getting more science to back up this, because most of these things have very large potential, but I think because we are commercializing products with these technologies already, without fully understanding the science behind this, we can damage basically the reputation of these technologies for future endeavors. So let's start with the stem cell therapy. So stem cell therapy, we know that, the first question is like, do we have convincing science-based evidence that links, sources of stem cells and benefits? Because this is the thing. All the stem cells are all kind of like, we say like they are pluripotential, so they can convert into whatever we want. Not all the adult cells can do that, and there is a certain level of limitation. So the most common source of stem cells is adipocyte-derived stem cells. So that means when you, for example, get, like a liposuction or fat removal for your body, you have a source of stem cells there that can be used to do other stuff, in your face and rejuvenate that. There are some issues here that I want to highlight. First, adipocyte tissue is highly inflammatory. So if you are in a state that you are overweight, obese, you have some other metabolic disease like diabetes, it's very likely that your fat tissue will have certain level of inflammation. Do we know what happened with those stem cells when we are under chronic inflammatory condition? We don't. Now let's look at the opposite direction with all these new drugs that are used to lose weight, basically, that are changing the ratio of muscles and adipocyte tissue, all of those GLP-1, drugs. The question is like, are they changing the environment for these stem cells that are so easy to isolate because they are in fat? And are we getting something different? We don't know. So when you are taking this drug like Ozempic, Mounjaro, or all of those, you're not only decreasing the amount of fat in your tissue, but are you affecting the, the viability of your stem cells? Are you affecting the way that they can differentiate? Are you affecting the number of them? We don't know. We need to figure it out this, because maybe because you're using this drug, you are basically compromising all these stem cells that you have there. And for stem cell therapy in the future, fat will not be your best approach. So that is something that we need to take in consideration. Of course, when it comes to stem cells, the best option is always embryonic cells, but they have several restrictions because embryonic cells imply, ethic dilemmas of, producing an embryo in vitro just to harvest the stem cells. So, but we have option for that includes adult stem cells, and these adult stem cells basically can be used for this. But we need to figure it out which are the stem cells that we want to use for each benefit. So we are not basically trying to figure it out if adipose stem cells will help you with alopecia, for giving an example. Maybe we need to go straight to hair follicles, like stem cells to do that. So the other thing that is important is, and this is valid for all the technologies that are involved in regenerative medicine, is to understand if there are protocols, and if we fully understand this protocol and they are fully standardized and they are reproducible, because this is super important. We want to have, if you need to do this therapy 3-4 times in your life or in a period of a year, you don't want to have, an issue with a non-standardized protocol. So you pay thousands of dollars for this therapy, and one time works and the other time doesn't work. We need to have scientifically standardized and reproducible protocols for the isolation, activation, and placement of these stem cells in our skin to see results. Now, the other thing that is important is like, most of the time, this is the way that we work with this, is like we are using our own stem cells, because, you get away with all the issues of compatibility or potential other diseases. My stem cells basically will cure me, which is the base of regenerative medicine. But how good are my stem cells? This will depend on your diet, your age, your lifestyle, genetics, etc. So if you have been smoking your entire life, if you have been exposing, if you have skin cancer, if you are not aging very well, are your stem cells good enough to be isolated, activated, and basically do a job? We don't know. So these are things that we need to understand, especially because stem cells regenerative capacity decreases as we age, as well as the number of the stem cells. So maybe the longer that we wait to use stem cell therapy is like the less efficacious that this will be because of all of these different conditions. Okay, so let's move to the next one, platelet-rich plasma, PRP. I have seen some amazing results with PRP, especially in hair growth. But one thing that caught my attention is like whenever physicians or researchers present the results related with PRP and hair loss, they make emphasis in very unique words. It's like, this is my protocol. This is what I do in my office. This is how I do it. This is the result that I get with my, parameters. So it's a very, it's very evident that we don't have a standardized protocol on this side. And that can basically result in different results. It can go from super good results and having hair regrowth very fast in a couple of months to nothing, basically. So it's very important that we standardize our way of talking about protocol too. So for example, when we talk about PRP, we need to centrifugate, basically separate the different components of the blood. And we usually talk about spinning and speed when we should be talking about RPM. So what we need to basically focus here, we need to focus on RPM because that is independent from the size of the rotor. So that will allow us to have, minimize difference in the very first protocol. That is, in the very first steps of the protocol, which is basically separation of the platelets-rich part of the blood from the rest. And there are several questions that needs to be answered. For example, hemolysis, is that good for the PRP? Affects the PRP efficacy? Does something to the platelets? Should we use hemolyze, PRP, or should we basically try to take blood again from the patient and figure it out what is going on? We don't know. What about activation? Is an activation a process that works, that helps with efficacy or not? We need clinical studies that basically compare activated plasma without activation from a control. Basically, we need a fully standardized clinical trial to see if this activation is a step that is required and is actually boosting the efficacy of PRP. The other thing that is important is storage. When you are getting you have the patient there, you're getting the blood, you are purifying the platelet rich fraction. Should we keep it at room temperature after activation, 4 degrees? For how long this is active? So I know some offices that send the patient with leftover plasma to their houses to put it like an hour or a couple of hours after a very invasive laser procedure has been done. Is this good, bad, not relevant? We don't know because we don't have a form of quantify or rapidly quantify the activity of that fraction that we are isolating. So it will be very nice to have something that is like dry chemistry, where you put a drop of that fraction and tell you you have this X amount of growth factor per milligram or things like that, because that will allow you to standardize and to tell the patients look, your PRP is below the average quality, and hence we are not expecting to see good result. And if this is the case, before doing a procedure and using the PRP that is below quality, maybe we can talk to the individual and say, to improve the quality of your PRP, we need to basically change your diet, your lifestyle. Maybe you have some genetic, issues that we need to address, and basically work for a couple of months to boost the activity of the PRP, kind of like overall healthy approach to the body, and basically get a PRP that has a minimum activity to produce results. So you see, this is basically, there is a lot of questions that cannot be answered right now. And I think we need to basically figure it out, the answers to move forward with a very successful approach, for example, to hair loss with PRP. Now, exosomes. Let's talk about exosome. An exosome, I was just in this meeting in Milan, and there were plenty of companies offering exosomes as the new solution for skin aging, for firmness, for post-procedure and things like that. And I have to say that I love exosomes. I think it's an amazing technology, but I don't think that we are there yet. So the first thing that we need to understand is like not all the molecules, not all the exosomes are, not all the extracellular vesicles are exosomes. So there are other vesicles that are similar in size to exosomes that are also floating in the extracellular medium. So the first step that we need to do is like, basically isolate the medium and separate this vesicle. And these vesicles have very similar, they have very similar size with exosomes. So it's very technically challenging to separate things that are very tiny and very similar in, like inside. This require some very complex techniques that need to be implemented. And the problem with this is the yield. It's like how many exosomes we are getting per liter of extracellular media. Are those enough? Do we need to have full, like containers of 500, 300, or thousands of liters to get enough exosomes to activate your paste? We don't know yet. Okay, so let's talk about purity of exosome. We say that there is, outside of the extracellular matrix, there are different type of vesicles. Let's assume that we can purify only exosome. Most of the time when you purify exosome, you use it, based on the size as well as the marker on the surface. So all the vesicles that have this specific marker is an exosome. But you have to remember that the molecules that are outside of the cells, the one that we are using to purify the exosomes, are the key to get into the host cells, the one that will receive the message, because exosomes are messages. But the cargo molecule, the one that are inside of the molecule, are the one that basically pass the message. So we can have exosomes that have different messages. So the question is like, do we need all of them? Or just we need to separate the one that have the specific cargo? So let me give you an example. For example, when it comes to growth factors, you always want to have blends of growth factors because the cells don't communicate with one growth factor. The cells, when something happened to the cell damage, when the cells produces growth factors to basically send the message or repair itself, is then a blend of growth factors that will do different stuff. So that is, basically the message is the collective information that you get from all these growth factors and their concentrations. So if you change the growth factor concentration, one goes up, one goes down, the message can be different. Is this the same case with exosome? Do we need all the messages together, but we need to standardize basically which will be the one that is higher or lower? Now, the other thing that is important when it comes to exosome is, as I say, the message is the unique cargo, and this is the one that triggers the response. So, and we need to understand that the message, the exosome message, is like a picture. Like the exosome that my cells are producing right now is a reflection of my cells' health, balance, and homeostasis right now. If a second after something happened, the production of exosome will change. So it's very important when we have procedures that standardize exosome isolation is to basically have exactly the same conditions to produce the same message. And that adds a different level of complexity to the already complex procedure of producing exosome outside basically, and in a high scale to have it, put it in products. So let's assume that we can purify exosome. Let's assume that we know what is the message and we like the message. So how will we keep it stable? How will we keep it stable in formulation? Exosomes are stable for long periods of time at -80 degrees. So, super frozen. So my rule right now, as it is, the whole field of exosome is like, I don't try anything that is not in a powder form, because anything that is in solution, probably they have no exosome. I haven't seen any data that convince me that you have exosomes that are active when you have something that has been on the shelf for 6 months in an office that is a room temperature best case scenario. So it's a big, big issue when it comes to exosome, the stability before and after formulation, especially of skincare. And the final thing is like optimal concentration to accomplish stability. So how many millions, billions of trillions of exosomes do we need to activate our cells? And I did an exercise here, and I removed the products that were basically here because I don't want to shame this company because they are only the 3 companies that are talking about the amount of exosomes that they have for products. So kudos to them for at least trying to do the right thing. So we have 3 products that basically have marketing material that claims to have a different amount of exosomes. And these are, if I remember well, there are different sources of exosomes. So product 1, it comes in a powder form, so lyophilized, and is, basically they are ready to be resuspended at the moment that you will use it. So this is kind of like what I was saying. It's like these are the ones that are kind of giving me the best hint for stability because they're in a powder form. And they claim to have 10 billions of exosomes in each vial, and it will be resuspended in 5 ml of a solution that they provide. The second company claims to have over 1 trillion of exosomes per bottle. And the third company claims to have over 1 trillion of exosomes per bottle. So as it is right now, the marketing procedure, we cannot compare this product because we are talking apples and oranges. So what I did, basically, I calculate how many exosomes they have per ml, considering the information, the second product has a 30 ml bottle, the third product has a 15 ml bottle. So when we compare apple to apples, the concentration of exosomes once that the products are ready to be used are 2 billions of exosomes per ml in the first one, 33 billions of exosomes per ml in the second one, and 66 billions of ml per exosome in the last one. This is a lot of exosome, isn't it? We definitely need to have some respond in the skin. But let me move this a little bit. But what is the ratio of cell to exosome activation? Because it's not that a cell sees 1 exosome and goes banana. It needs to have a threshold. It needs to have a minimum amount of exosome in the cell to basically produce an activation. And in vitro data, so this is Petri dish, cells there exposed directly to the exosome is around 1 to 10, 1 to 100, depending on the type of cell, depending on the quality of the exosome. There are several factors, but let's use these 2 parameters just to do a rough calculation. And this is a rough calculation, as I mentioned before. And I have some consideration after this slide to basically understand a little bit what is going on. So we have 1 square inch of skin contains about 20 million cells. And in average, our human face is about 100 square inches, which means that we have in our face, in an average face, 2 billion cells that we want exposed to exosome. We are not considering here that the exosome will only target, like epidermis or dermis. We are assuming the exosome will target every single cell in our skin because we don't have the information to figure it out. So a 1 to 10 ratio, basically for a cell to exosome, will require about 20 billion of exosome for the entire face. A 1 to 100 ratio will require 200 billions of exosome for the entire face. So if we look at, how many exosomes each of these products have now, not the concentration, but per single use, so a pump of this product, how many exosomes will contain, the product 1 is a single use and basically will give you 10 billion of exosomes. Product 2, 1 pump based in a pump of 0.5 ml will give you 16 billions of exosomes. And product 3 will give you 33 billions of exosomes. So still means nothing. Billions means a lot, basically. Are we reaching the 1 to 10 or the 1 to 100 ratio for a minimum activation? As I say, we are not considering a lot of issues here. And so what we did after this, we calculate basically if this is enough. So the ratio of cells for your entire face per exosome for 1 use of this product, for the product 1 is 1 to 5, the product 2 is 1 to 8, and the product 3 is 1 to 16. So they're all on the lower side of this activation ratio. And let's assume that what we need for the face is 1 to 30. None of them are reaching that level of activation with 1 application. So are we there yet? Because when we see the marketing, I said, like, you have 1 trillion of exosomes per bottle. It looks like amazing, like, oh my gosh, these are so many. But when we do this type of math, it's not that enough, basically. Maybe we are not getting there yet. We don't know the cumulative effect. So basically applying this under activation ratio of 1 to 5 for many, for a month or so, if that will basically produce a response. We don't know that. But this is, as I say, a very rough calculation to show you that trillions of exosomes per bottle doesn't guarantee you the minimum ratio of 1 to 10 to basically have a response in vitro. So what are the things that we need to take in consideration? So as I say, this is in vitro data. That's not considered issue of skin penetration, which is a very huge issue when it comes to skin cares, because the skin is designed not to allow you to penetrate, like not to allow substance from outside to go inside. And the healthier that skin is, the harder that is to produce skin penetration. We are not considering bioavailability. What happened with the exosomes? Let's assume that the exosomes are fully stable in the bottle. What happened when they go into the skin and they encounter this very aggressive, like extracellular matrix with like enzymes and proteoglycans or like different, like type of molecules that can sequestrate them, that they can destroy them. Maybe the cells will never see them. We don't know. We have no idea what is the bioavailability of these exosomes once as they cross, if they cross the barrier. We say, we talk about the stability in the formula. We don't know if these measurements that, for example, these companies are putting out are fresh produced product or the one that were close to expire, like 2 years after the production, or if there were products that were controlled in controlled environments, like temperature control, humidity control. So the best case scenario, we don't know because that is not provided to us. The type of exosome and which cells are targeting, that is what I say, like basically all my calculations are based on the entire phase and all the cells being exposed to exosome. We don't know if that is the goal of the company. We don't know what type of exosome they have. So it's, everyone's guess here. And the method that the companies use to estimate exosome number per product, we don't know if we can actually compare apples to apples, what one company decide is an exosome and the other company decide what is an exosome. We don't have a very clear definition saying like exosome were purified using blah, 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 blah. We don't know. Hence, it could be that they are using different methods and they are detecting different stuff. We don't know. Okay. So finally, let's go a little bit and talk about biohacking therapies. And this is something that is getting really, really popular, especially in the United States. And this is a new trend in the beauty industry that focuses on science-based, and I will do the bunny ears, science-based intervention to slow down, revert, or prevent aging. The reason why I'm doing this is because everyone talking about science-based, and we will see with one example that we don't have enough science-based to do anything with this active ingredient. So the most common drugs used by biohackers are, as an anti-aging drug, are rapamycin, metformin, and nootropics, which are prescription or non-prescription drugs. And this is a list of the most common things that basically supposed to basically alter your brain function. Okay, so let's take rapamycin, because rapamycin is everywhere right now. And I know a lot of people that are taking rapamycin as a preventive anti-aging, therapy. And I'm not sure if we're there yet. So there are several thousands of papers published with very good data indicating that rapamycin is involved in stopping or delaying aging-related diseases in vitro models or in worm models or in some animal models. But what about human? Because I'm not a mouse, I'm not a worm. So I want to know if these things work in human. So I was looking into PubMed to figure out how many, clinical research were done. And this author basically saved so much time because they did the work for me. And they have basically a summary of all the clinical studies that have been using not only rapamycin, but some analogs of synthetic analog of rapamycin, and basically studying different organs in the body and how this was, affected. The time, the dose are all different. So it's impossible for us to group all the studies, or these 19 studies, by the way, 19 studies in humans as an anti-aging, basically, that can provide us with information for is this good or bad, or is doing something to prevent aging. So what I did here, I basically grouped the studies. You have studies in healthy individuals that contains, in summary, basically all the groups are around 2,000 people. And studies in aging-related diseases are 400 people. This is way, out of the league of the FDA-approved studies. Remember, we talked about that to be allowed to say that therapy, it can be used as a regenerative medicine, the FDA need to oversee your studies. Well, this basically, remember, FDAs are thousands of patients, thousands, like 10,000 of patients to show and control groups and all the stuff. Just looking at this summary, you can tell these are very good preliminary data, but not enough to basically get an FDA approval, that is for sure. And when you look at the plot here, you can see that different studies investigate different effects of rapamycin in different organs. For example, some of them in the brain, muscular, cardiovascular, endocrine, reproductive, immune system. Basically, we have like individual studies showing some small result or big result, but nothing that we can basically group and say, like study after study have shown improvements. The other thing that is important here is to remember that these are not only made with rapamycin, but they are made with a synthetic analog of rapamycin or molecules that intervene with the pathway that rapamycin activates. So it's very hard to compare. But this is the science-based thing. This is what we know. We have enough data from the preclinical and from the animal model that suggests that rapamycin could affect aging in disease. We don't know what rapamycin does in healthy, youthful individuals, and what will be the long-term effect of rapamycin in these healthy, youthful individuals if they continue, having a healthy lifestyle. So, but as I said, before, marketing takes the wheel when it comes to anti-aging. And if you go to Google, you can buy rapamycin, basically. You can buy topical rapamycin, you can buy pills, you can even buy rapamycin for your dogs. And what, like the marketing is saying, and I just took a couple of like examples here, it's like topical rapamycin for the skin, scientifically proven to address the root cause of aging. This is a very bold claim, because what you are telling basically to people is like rapamycin will basically prevent skin aging, and we don't know that. We have no idea. We don't even know if rapamycin in that product is delivered to the skin. Other, like claims that we have is like rapamycin, for example, explore the most promising longevity therapy today with ongoing monitoring of your blood. Basically, you need to get more things from this company. You need to monitor your blood, your markers, your aging marker. Who knows what are the aging markers that they are using to tell you that rapamycin is working. And the most beautiful thing to me was like when they're offering rapamycin for dogs, so your dog can live, like longer. And still, we don't know if that is the case. So as you see, marketing took the wheel with rapamycin. We already have commercialized, products, and we still don't know what is the effect of rapamycin on the skin when it comes in a skincare product or when you are taking this orally. Okay, so what are my final thoughts on all of this? When it comes to regenerative medicine and aesthetic, I always say I would like to take the words of Aerosmith. We have to learn to crawl before we learn to walk. We are basically running with this, running with scissors, because we don't know if these products are, or these, like supplements are doing good long-term or not. Because the worst case scenario is like, they're doing harmful things, but it could be that you're spending hundreds, thousands of dollars and you are not even moving the needle a little bit. The other thing that is important when it comes to regenerative medicine is like, what are the patient expectations? Because as I said before, retinoids and antioxidants are doing an amazing job, and yet they are doing regenerative medicine. They are changing, how the skin functions, and the structures are being rejuvenated. But when patients listen to you talking about regenerative medicine as the new frontier, their expectations are not the same one that you are seeing, and they are expecting that they will go to your, they will start the treatment like looking at the first picture and leave the office, or a couple of months after looking at the last picture. So it's very important that we set expectation for this. And this is not a magic wand or the font of youth that will revert aging in a blink of an eye. It's a full process that we need to take in consideration. Okay, so thank you so much. If you have any questions, here is where you can find me. And soon I will have another talk. So take care.